Hello, everyone. Welcome to this webinar where we're going to be looking at embedding values in mental health care and taking lessons from the life in the case of the Esidimeni case. This webinar is actually the genesis of it, the germination of it goes back several years to conversations that started between World Values Day, and I'm the global coordinator of World Values Day, and we're one of the co-hosts of this webinar. The conversation started between World Values Day, the International Working Group for Health Systems Strengthening, which is Bettina Baidu and her colleagues, some of whom are here today, and Tariqin Global, represented by Katrina Ramage, who's here today, and Prab Mistry. And we started talking about healthcare from a global perspective, the work that IWG was doing and Bettina and colleagues were doing. And out of that, an initiative crystallized, which we called the Movement for Equitable and Sustainable Healthcare, MESH for short. And our aim is to bring together all the relevant groups and organizations that we could find that were interested to develop a broadly based and multi-year initiative focused on redressing global healthcare inequality. Because as we all know, there's a huge difference between healthcare in many parts of the global south and what is generally the case in the global north. The global south is often underprovided, but often much less effective in the provisions that are made. And we believe that the opportunity presented by the G20 summit, which is in South Africa, as most of you know, coming up shortly next month, and our existing involvement in the Values 20 engagement group, which has been for the last few years trying to get values into global policymaking generally. That was a great opportunity for us to bring our initiative to the attention of the world. And so we are particularly happy in that context to welcome to this event, this webinar, the Collaborating Centre for Values-Based Practice in Health and Social Care, who are jointly hosting this webinar with World Values Day, with Values 20, and with the Working Group for Health Systems Strengthening. Today's session will be 90 minutes long, and we're going to be looking at really what's going wrong at the moment with healthcare systems. And a lot of, in my opinion, certainly, and I think the opinion of many of you, a lot of what's going wrong is to do with values and the apparent lack of them in many healthcare situations and healthcare systems. And so we'll be highlighting the role, the critical role, we'd say, of values like dignity, accountability, compassion, and Ubuntu in strengthening healthcare systems and preventing systemic failures of the kind that we've seen. And the life Esidimeni tragedy will be a focal point for this and how we explore this failure, but also explore how, looking at the positive side, how values-based approaches might be able to transform mental health care and the broader health service delivery. We'll also be connecting, this discussion will feed into, one way or another, into the outcomes of the Values 20 communique to G20, which it'll be presenting, Values 20 will be presenting in 1 week's time, next Thursday and Friday at their summit, the V20 summit. And so that summit will hopefully, and that communique will showcase key policy recommendations which Bettina and her colleagues in the healthcare stream of the V20 have been working on, largely based upon the studies that we've been doing, that Bettina, Mesh, and her colleagues, our colleagues, have been doing. So just looking at the way this session will work, We're going to have, after these remarks by me, I'm going to be introducing you to Professor Ashok Handa of the Collaborating Centre for Value-Based Practice in Oxford, who's going to tell us about the work of the centre and how that's relevant to these global issues on healthcare that we're talking about. Bettina Wabeng Baidu is then going to be speaking about giving us an overview of the Values 20 community, the work that it's been doing, some of its key recommendations, and how they're relevant for healthcare and mental healthcare and general healthcare. We're then going to hear from Christine Samalo, who, as most of you may know, is a member of the Life Ceremony Family Committee as a result of her personal family connection with that tragedy, and has been a staunch campaigner and a very energetic campaigner for change, for justice in the case of that tragedy, and more generally for change to be made to prevent that sort of thing happening again. We're going to then be hearing from Prabodh Mistry, who's one of my MESH colleagues, who's going to provide an analytical perspective of how these values that we all hold so highly, and indeed people throughout the healthcare systems hold very highly, how it is that these were absent or undermined in the case of the Ensedemi tragedy. And then we're going to have a panel discussion with a lot of the people involved in that particular case, but also involved in these issues more generally from different perspectives. Bettina will be introducing all these speakers as we go along, and then we'll have time, I think, for hopefully 15 or 20 minutes, maybe more, maybe less, for general discussion, for questions and answers. So please, if you have questions as we go along, do put them in the chat as we go along, and rather than raising them now. So I've probably gone a bit long. We're already overshooting, my fault. So without more ado, I'm just going to introduce Ashok Handa to you all. As I already said, he's one of the leading lights. He's the co-director of the Collaborating Centre for Values-Based Practice in Health and Social Care, which is based at his college, St Catherine's College in Oxford. Bill Fulford, I should say, is also with him. You can see in the background behind Ashok's left shoulder, who's the other co-director of the Collaborating Centre. And he is a professor of vascular surgery, director of teaching in surgery at Oxford University, consultant vascular surgeon at the John Radcliffe Hospital in Oxford, and responsible for, he's a fellow of St Catherine's, responsible for educational research for the centre as a whole, for the Collaborating Centre as a whole. So over to you, Ashok. Please tell us about.
Great. Well, thank you so much. And I'm really delighted to be here representing the Collaborating Centre, and I'm delighted that Bill Fulford, the founding director of the centre, who's much more aligned to this because he is a now retired psychiatrist, but also a philosopher. Whereas you might think, well, what has a surgeon got to tell us about the issues around mental health? And maybe I can elaborate on that. So the Collaborating Centre was set up really as a joint effort between Bill and me with the governing body at St Catherine's College 12 years ago. And the purpose was three parts of work. One was a very academic but philosophical background. So quite a lot of work in philosophy on values. And that came originally from Bill's doctoral work many years ago. But the second part was to work with within the UK with the regulators of healthcare and the healthcare professions around how do we try and embed values and values-based practice within the regulatory framework. And then a third, equally, if not in some ways more important part, was in education, and starting with education both at undergraduate levels, interprofessional education, on the basis that in healthcare, we're still trained, sadly, in silos, whether it's nurses, doctors, paramedics, osteopaths, pharmacists, but we work in teams. and we thought that interprofessional education for values particularly was important. So those are our sort of three streams of work. And I guess the question would be, well, how do we do it? Well, we do it through hosting 17 networks, some in very niche areas, but there are ones in, for example, public mental health, but also organizing between 8 and 10 one-day seminars year round. And these are mostly pre-COVID were in person, but now tend to be hybrid events. But our preference is for as many people as possible to attend in person. And we've been funded through a charitable donation from the Laces Trust for the last 12 years. And I'm really pleased to report that we now have embedded funding for the next 10 years, so that, as a centre, we're really here to stay. Now, one thing that has taxed me and Bill quite a lot is the word values in healthcare, certainly in the UK, is bandied about a lot. And for example, in the National Health Service, the NHS on its website will say these are our values. Every single healthcare provider in the UK is required on their website to talk about their values, and Evan has done some work about it. But and so it's common parlance in society, the word values. But when you ask people to actually say, and we use this as a training exercise, a 3-word exercise, write down 3 words or very short phrases that mean values to you, something very strange happens. And what happens is that, and I've now undertaken that exercise over 450 times in groups as small as 8 to 20 and as large as 670 in the Sheldonian Theatre in Oxford. And we find that very rare for 2 people in the room to have exactly the same 3 words. And what that really demonstrates is the huge heterogeneity of values. So we might even come from very similar backgrounds. For example, we have an undergraduate course where we recruit 18-year-olds. We're trying to diversify in medical education in the UK where people come from. But regardless of that, very rare for them to have 3 words exactly the same. And I think in those 450 times I've undertaken this exercise, it's only 3 times I've come across 2 people in the room with exactly the same 3 words. So I think that I just wanted to make that point around how values are commonly used, but commonly misunderstood. And I think that's the challenge for those of us in this room and those of us around the world working on values. One thing that helped us in the UK was 10 years ago, a single case that went to the Supreme Court called the Montgomery judgment. And essentially, the Montgomery judgment, through case law, requires all healthcare workers to consider the individual things that are important to a person in a particular situation and embed those in the decisions made about their healthcare. And that could be decisions about the diagnostic framework, or it could be about treatment options. And the challenge for the last 10 years has been getting particularly doctors, but other healthcare workers, to embrace the use of values and having a dialogue with patients about what's important to them rather than what's been necessarily important to healthcare workers or the healthcare organization that delivers care. We have later this month our 10 years on conference on Montgomery and me. And I wanted to just share something that I call the 3 decisions model. So this is how it has changed my practice as a practicing surgeon. And for 3 or more decades, I've been teaching students and other healthcare workers and colleagues in surgery around how to make decisions. And I've said, well, it doesn't matter where you are, whether you're in the operating room, in the clinic, on a ward round, in the emergency room. There seem to me to be 3 types of decisions to make. One is where, for a particular patient with a condition, the evidence is overwhelmingly that a particular course of action has huge benefits and very low risks. And an example from my specialty in vascular surgery might be if someone has had a mini stroke and they've got a very narrowed artery in the neck, a carotid artery, the evidence is that having surgery called a carotid endarterectomy, as well as best medical therapy, reduces their risk of stroke from nearly 20% to about 3% in the next year. And I can make a recommendation. Now, patients might say no, and if they say no, I'd want to explore with them, why have you made that decision? And I want to make sure that I've articulated the risks and benefits to the patient. And at the end of that process, they can still say no. And I'll give you an example. About 6 years ago, I had a early 80s-year-old retired GP or general practitioner, you might call them family doctor, who had the same problem, and he said, "Don't be ridiculous, young man. I'm far too old to have this dangerous operation." And I went back and explained that it was done under local anesthetic. It was extremely safe in our hospital and in my hands. He said, "Well, that's for me to decide." And we left that. And I gave him my secretary's number. This was on a Thursday. He actually called back on the Monday, and my secretary phoned to say that Dr. X wants to talk to you. He said you'd be happy to call him back. And I called him back and he said, "I've changed my mind. I'd like to have the operation." I said, "Well, I'm interested. Why did you change your mind?" And it turned out his neighbor was probably the best known neurologist in the world, Peter Rothwell, who told him, yes, the evidence was he should have it done, and that I was quite good at it. Now, I took objection to that because I thought I was better than quite good, but that's just a surgeon's arrogance, probably. The second type of decision is where the evidence is overwhelmingly that a particular course of action, which often the patient is seeking, has huge risk and very little benefit. And in that case, my practice is to say, I'm not going to offer you this treatment. These are the reasons why. But you can usually tell if someone's unhappy. And my practice has been that if I can see if someone's unhappy, I'll say, "Well, you seem a bit unhappy with that. Would you like a second opinion from one of my colleagues?" And I will facilitate that. And I always thought that seemed like quite a good way of approaching it, by voluntarily, unsolicited, offering a second opinion. And that worked quite well for a little while. And then about 5 years ago, one of my patients said to me, "Well, you would say that, wouldn't you?" And I thought this was quite a strange response. So I said, I'm sorry you think that. What could I ask why you have that reaction?" And he said, "Well, because they're all your friends, aren't they? They all say the same as you." And I had to stop for a moment and reflect and say, "Well, I can understand, Mr. Jones, why you might say that. Actually, you're right. The other four are my professional colleagues. By the way, only one of them is my friend." So that might tell you that just because you work well with somebody, they don't have to be your friends. But I changed the way I approach that now. And what I do now is say, "Would you like to see one of my colleagues in Oxford or any one of the academic centres around us, London, Birmingham, Southampton, Bristol, etc.? And I find that if you offer that unsolicited, only about 1 in 20 patients take up that offer. And if they do, they virtually never come back, either because they found someone who maybe has values aligned to them, or they've given the same response and they're not going to come back. The third type of decision is where there might be more than one possible option, maybe up to 5. And what I've said to people in the past used to be, well, you can have treatment A or B or C or D. Here are the risks and benefits. You choose. And until I met Bill, I thought I was doing quite a good job by that. But of course, you will all be thinking, well, what would your response be, or response of your patients, of your clinicians? And it turns out that around 85% turn around and say, "Well, what would you do, doctor or nurse?" And before I met Bill and before I looked at the Montgomery judgment, I would say, well, in that case, Charles, I would have treatment A, and Bettina, you can have treatment B, and Sasha can have treatment C, etc. And that was based on my clinical expertise. But having thought a bit more about values, I have to realize that not everyone thinks like me. And so what I do now is to say, well, I have an idea of what might work for you, but why don't you tell me a bit more about what's important to you in this circumstance? And then together we'll find the thing that's going to suit you the best. And an example could be from someone with varicose veins, where you can have no treatment, you can have compression stockings, you can have injection sclerotherapy, you have laser treatment, or you can have surgery, and each of them have different risks and benefits. So it does involve a slightly longer dialogue with the patient, but in general, the patients are happier at the end because they've been part of that decision. Now, I have to say that sometimes, despite that conversation, patients look at me as if I'm completely mad and say, well, but you're the expert. Why don't you tell me what to do, doctor? And my response to that is, well, actually, to make this decision, we need two experts. We need an expert in vascular surgery, and we need an expert in you. I'm one of those, and you're the other. And so that's why we need both of us to make this decision. So that's just to give you an example of how thinking about values has changed the way I work in the clinic, on a ward round, and in the emergency room. The final thing I wanted to say was to try and bring this back to why it might be relevant to the work that the V20 group are going to do and take to the G20 summit, because clearly there's a massive problem with mental health and the inequities across the globe. Well, actually, it turns out that that's a shared problem with surgery. Now, 10 years ago, the Lancet Commission in surgery showed that there are 5 billion people in the world who don't have access to safe surgery, and 1.7 billion of those are children. And one of the things we're now doing is at our annual global surgery course, where we predominantly look for people from those defined as low middle income countries, and we provide at least 50% of the ones who come with a bursary to come to our training. We have now embedded this year training in values-based practice as part of that, to try and have the same impact on decision making in surgery across the globe as you're trying to make with mental health. So that brings me back to why I think maybe I have a little bit of a role in this, on the basis that we have a shared problem in surgery with mental health provision, and how values are particularly important in empowering patients and us making good decisions with them. So I'm going to stop there, Charles. I might be slightly over time.
Fantastic. Let me just thank you so much indeed, Ashok. So let me just find your, sorry, I'm trying to remove the spotlight and you've jumped out of my list of attendees for some reason, but never mind. I'll work out a way to do that. And we'll hand over to Bettina.
Thank you so much, Charles. Thank you. Don't worry, I will remove the pin. Spotlight. Thank you so much, Prof. And I think that was such a lovely introduction. And just as you were speaking, I was thinking today about all the patients, we saw on our ward round, and how little patients were involved in decision making that was happening in their health, not only about the decisions that they had to make, but even when it comes to surgery. So thank you so much for highlighting the role that values can play in health. And I think as the V20 community and the health equity community, we believe that, values have a role to play in every level of the health system, from the bedside that we are at with the patients, which you have just currently explored so well, all the way to policy making and decision making within health systems, which are all truly values embedded, and values essentially are a reflection of the values that we hold true as a society. So really thank you for that introduction, and welcome everyone to the session. This is the lead up to the Values 20 conference, which will be happening on the 16th and 17th of October in Cape Town. It will be a fully hybrid conference, and as the Values 20 community, we've been trying to highlight this year the importance of embedding values within health systems and showcasing why a more values intentional approach is necessary to reshaping health systems. And as a community, we were tasked to come up with one case study that we felt really highlighted or advocated for the need for values. And that case study for us was the Life is Sidimeni tragedy, which we believe showcases what happens when we make decisions and policy decisions in a values vacuum without a consideration of the values that we hold true as a society. And that's why we're all here in this room and how this conversation ties to the case study we're going to be exploring in a few seconds. I'm going to quickly just share my screen for about 5 minutes and just walk you through the work that we've done so far as the Values 20 community and as the MESH community. So I hope that my screen is visible. And then we can just play it from the start. Is it visible, Charles?
Yes,
Yes, it is.
Thank you so much. So we were invited this year to contribute to the Values 20 communique, which will be presented at the social conference of the G20 conference, where social groups will come together to give their recommendations to G20 leaders. And to write those recommendations, we work together with the International Working Group for Health System Strengthening, which I have the privilege of being the co-director of, and with Joy and Ramonde, who are also in this call today, as well as with the World Values Day group, the Tarakan Global Group, and the EHV Engineering. So the Values 20 community, as we explained, is a community that seeks to influence the G20 and to highlight the importance of values in policy decision making. This year, the V20 community has been really trying to advocate for 5 key values: for dignity, ubuntu, ethical governance, ownership and agency, and equity, under 3 key streams: the streams of solidarity, equality, as well as sustainable development. The communique that has been written and has been divided into these three streams, and showcasing how these 5 values can help us have better solidarity, creating equality, and ushering in sustainable development. As the health equality group, I think when we were asked the question, what is the role of values in health systems? The answer was just overwhelming. We think there cannot be a conversation about health systems without values. We know that values influence not just how health systems are designed, but health systems also impact on values. If 5 billion people don't have access to surgery, that means that 5 billion people might have to pay high out-of-pocket payments in order to receive a surgery somewhere. And that will impact on inequality, on dignity, on ubuntu, on agency. So there's a twofold relationship between values and between health systems. They influence one another and they're deeply embedded within one another. Every conceptualization of health systems places values at the core of it, because essentially health systems are human systems that are made by people and therefore influenced by people and the decisions that they make. So we identified a number of challenges that we spoke to in the communique itself. Oops, sorry. Where do I change? Okay, so some of the challenges we've spoken to in our communique have been highlighted by Prof. Handa. And Prof. Handa, we also hosted a webinar a few weeks ago on global surgery and the role that values play in global surgery, because as you've highlighted, that is also one of the key areas where we are seeing a values gap in terms of equality. But some of the challenges that we highlighted in our communique were around the persistent structural inequality of health access that we see quite starkly here in South Africa, being one of the most unequal countries in the world, where 51% of health spending goes towards only 14% of the population who have access to private healthcare. And the other 49% has to serve over 84% of the population who aren't able to access private healthcare. And that leads to stark inequalities in patient outcomes between the haves and the have-nots. So we think that this, our nation, really is an example of health inequalities. This year, we've been challenged with decreasing fiscal space, with USAID, reducing the funding for many health projects and many countries withdrawing funds. Between 2021 and 2025, we've seen a decrease in 70% of aid that's been given for health reasons. And this is challenging health systems everywhere to redesign themselves. We're also seeing a neglect in quality. This has been a very important one for us as the Values 20 community. So even though universal health coverage emphasizes access and financial protection, we've seen a lack of focus on quality as an important metric. Even though the Lancet Commission found that poor quality healthcare is more a reason for mortality nowadays than lack of access in itself, highlighting the need for us to think not just about people receiving care, but how they are receiving care. And that's a key area where values comes in. Other challenges include the pandemic preparedness, the need for us to be ready at all times for the re-event of something like the COVID-19 pandemic, the rising burden of non-communicable diseases, and mental health and injuries, which is why we are here today for this webinar. We're seeing that over 80% of deaths from non-communicable diseases happens in low and middle income countries. And there is a need for us to redesign health systems from a values perspective to be able to respond to that. We're also facing a health workforce crisis as well as the risk of deepening the digital divide that we have in our world. So we have a number of recommendations that we are going to be speaking to at the Values 20 conference, which I'm going to post in the link and inviting everyone here to participate in. I won't spend too much time because I really want us to get to the core of this webinar today, which is the case study that we have present. But the key thing that we are advocating for as a values community is the need for us to integrate quality within the way we are restructuring health systems. And quality requires us to have a values-based approach, because quality means that the person receiving the care receives care that is dignified, respectful, that sees them as a human, and as Prof. Hunter explored, that takes their agency into account when making decisions about their healthcare. They are the experts on their own health. And we think a more values intentional approach can move us into a place where we can really have better quality health systems. So we have a number of recommendations in terms of how we think this can be done, as well as policy recommendations of how do we really embed values within health systems. One of our key policy recommendations is developing a national values-driven quality policy and monitoring framework in all countries, and those quality frameworks really embedding values like ubuntu, like dignity within how we are tracking health systems. So when we speak about health systems, not just reporting on mortality, but reporting on the level of dignity that patients are experiencing of their own care, or the level of respect of their own care. So really changing quality metrics to be as values intentional as possible, and that highlights some of the policy recommendations we are making at the V20 conference, including a few more. But I won't spend too much time here because I really want you to come to the conference itself. We're going to be hosting a Values 20 or a health equality section on the 17th of October at 2 p.m. South Africa time. And we will send the link to that session to everybody who's joined this call today. But that gives you some highlights in terms of the work we are doing at the health equality section and the recommendations we're going to be making to the G20 conference, which will also be shaped by this webinar today. So let me stop sharing there. And I think when we wrote this communique, one of the things we really wanted to do was to highlight why we thought values were so important and were so crucial. And unlike the other streams, we took a bit of a different approach. We chose a case study that didn't necessarily show the way that values can change something, but actually showed what happens when there was an absence of values and value-making decisions within health systems. And that led us to the Life is Sidimeni tragedy. And this tragedy is the cases that we focused on in our discussion today. And I think to really talk to you about that tragedy, I think I would love to, at this point, hand over to Ms. Christine Nxumalo. Ms. Christine Nxumalo is a leading Life is Sidimeni activist and mental health advocate in South Africa who was propelled into advocacy after losing her sister in this tragedy that claimed 144 lives in South Africa. And to me, this tragedy continues to mark one of the worst cases in our nation and in our nation's history. As a member of the Life Esidimeni Family Community, she continues to champion accountability, humane policy, and ethical oversight in mental health care, and has contributed to the Life Esidimeni Live Lost work that seeks to really highlight this work. So, Ms. Sumalo, thank you so much for joining us today. And I would love to hand over to you because I think we can't do justice to this case study without really hearing from those who were actually affected by it. So thank you for being.
Good afternoon, and thank you so much for the invite. And I think also just thank you for actually highlighting the Life Esidimeni matter or tragedy. Sorry, I just got a bit incredibly emotional when the previous speakers, I think the one that got me was the Montgomery judgment. If you look at the Life Esidimeni, you'd understand why that would hit so hard. And then the value-based approach, which were both absent in the Life Esidimeni process, or that led to the tragedy. Now, I consider myself as an accidental activist by virtue of the fact that I was made aware of mental health when my sister obviously became sick. And we had to go through a process of, taking her to the doctor and the whole process that led her being admitted to Life Esidimeni. So before then, you would have asked me anything about mental health, I probably would not be able to answer you and not even know how to respond. So that is why I'm an accidental activist. So apologies about that. And basically, my sister became ill. Not too long after that, she was admitted into a life facility. And we were told that there was no other option for her. She needed assisted care. So it wasn't something that we really had an option. You know. So when she was in life, she was in there for about 2 years. So it wasn't a long relationship that we had with the life facility. So imagine when we finally, as a family, have gotten to this to accept, because we had to go through counseling ourselves. We had to accept that our sister could not live with us anymore, and that she had to be in a facility, I suppose, for the rest of her life, actually. And we could only have certain periods of time because of life, because of, we had to, I suppose, get on with life. So 2 years later, after having her for December, we are called in and told that the facility needs to close. That didn't make any sense to us, and we didn't understand why. Why would it close? We were simply told that it was because of funds. And we're like, what do you mean funds? This is a government-funded program. So if it means we contribute as families, allow us to do so. But this is the best facility. Safe to say that value-based approach was nowhere. We went from, we are going to consult, we are going to talk about the options that are available, we are going to look at what we can do, to literally getting messages from family loved ones saying that some of our loved ones have been loaded onto trucks, held by cloth and whatever else that could hold them up, for them, I suppose, not to fall off the trucks or fall off wherever, to be moved to different places all across Gauteng. Now, I can't begin to tell you. I could not. I remember I had met Section 27, Sasha Stevens at the time. And she was saying to me, she gave me a brief before the whole process started, and basically said, look, they've been trying to close the facility, but we had taken them to court. But because of, I suppose, they have ways of doing this, they were able to then get the judge to allow them to go ahead with this process. So while we were waiting for a process to unfold, because we were told, no, you will be consulted, we will look at, we will sit down with you as a family, look at the patient, which is that value-based approach that was spoken about earlier. That did not happen. We started getting messages that our loved ones were moved. In my sister's case, on the 30th of June, I'll never forget that, I got an SMS that said to me that she's been moved to Pretoria somewhere, and if I needed to get hold of her, I must go there. Now, my sister had motion sickness, so just getting her into a car, we had to drive extremely slow. So you can just imagine that trip from where she was to Pretoria, which was quite a distance. We couldn't find her for a good 2 months, 2.5 months. We phoned every possible place we could phone, couldn't find her. Until I got the call in August 2016 to say she had passed. I was called by some Ethel Nube, who was the NGO owner, and she told me that she had passed. So my initial questions was, who are you? How did you get hold of my sister? How was she brought to you? And of course, as you can imagine, everything just started unraveling, unfolding. But when it was time for me to get my sister's body, that's when it started getting a bit strange. I couldn't get this woman to release my sister's body. I had to call Section 27. I said, I need your help. Something is happening that I don't understand. Eventually, because of Section 27 getting involved, and of course getting the police, the station commander for the police station nearby to assist, we were then told that, I suppose when we went to go and visit the NGO where her body was, the lady who was working there said to us, oh, your sister's lucky. And I'm like, what do you mean lucky? She's like, there's others that have been here for months. And they died and nobody's come to fetch them. And this is the call that actually unraveled the entire tragedy. Because I immediately called Section 27 and I said to her, Sasha, I just got the most chilling news ever. I was here to collect my sister, but actually it looks like I'm here to collect a whole lot of other people indirectly, because then it means we can access their families and tell them what is going on. And this was the beginning of the tragedy. Section 27 obviously did their work, and this is now where we started getting the numbers. The initial number was 37. The others were, and the numbers, as you could, I don't know if you guys recall, but we went from 37 to 97, and before long we were at 144. So this entire time, we immediately, I think I was one of the lucky ones that then said, do a post-mortem. Because for me, at first, I honestly thought it was an innocent thing that they took my sister and she possibly died. And I was hoping to get simple answers. But instead of getting any answers and having to call on help just to get a body, we were asking for an inquest, get the NPA to do an inquest. They flat out refused to do an inquest. So we went literally from one pillar to post, just trying to get answers. Managed to bury my sister. And it's been a fight ever since, because like I said, the numbers kept piling. But basically, what the post-mortem, which by the way, I only got to get, I think last year, after all that time, since 2016, I only got my sister's post-mortem last year when we did the inquest, eventually. And basically, they took her and they just left her in a room. No water, no food, no movement of any kind, because she then developed gangrene in both her feet. So she basically waited to die. This was happening while we were searching for her frantically, trying to reach her. So you can imagine when people before me speak, the smallest thing just is a trigger, because you're trying to understand how anybody could do that to somebody. Never mind 144. We're at a point where we're still struggling to put up a monument from the very same government that promised to do a monument. In fact, they didn't promise, they were told as part of the arbitration award. I'm also very emotional today because her daughter died a year later because of heartbreak. Sorry, I had no intentions of getting emotional. But yeah, no, the tragedy was probably the most horrific experience for any human being. To watch your loved one die for no reason. Because the option that the department had was to give her back to us. And we find a way of surviving, of living. She would have at least been safe, if nothing else. But to leave her in a room, in fact, to move all of those people the way they did, for apparently saving money. So can you imagine if we had the Montgomery judgment? It would have forced them to do something, or at least consider. Mental health in South Africa is not a thing. Trust me, I think after the Life as City Many matter, there was a lot more talk about mental health. You know, everybody talks about mental health. Everybody knows depression and anxiety and all that is mental health. But nobody actually invests in mental health. The little budget that we do get from the department, if there's any shortfall anywhere in the system, that's where they go to take money to solve other problems. So it is not there's no considered effort and concerted effort to actually fix the space. I mean, they moved our loved ones from Life as City Many, which was the best option at the time, moved them to ill-equipped NGOs who did not have licenses, who did not have professional people, who didn't even know what mental health was themselves. Never mind looking after people with mental health. Only for the whole process to collapse and people die, and they go right back to Life as City Many. So you see, this was, it seemed like a game. It seemed like a power play. I don't think they anticipated the deaths, even though they were warned many a time. But now we're at a point where we've gone through the arbitration. We eventually got the inquest. And the NPA has been quiet for a very long time. They recently came back to us and told us that of the 144 patients that died, they can only prosecute for 2. Now, you can't begin to imagine the shock and the anger that the families expressed. To say, we were at 144 at some point, and then for the inquest, we had to look at 9, and now we are at 2. The families rejected that and said there is no ways. Now, you must remember, Section 27 has been part of this process right from the beginning. The amount of evidence that they managed to put together through the arbitration and then through the inquest, for the NPA to say they don't have enough evidence to prosecute. And by the way, the reason why they were only, according to them and according to the briefing they gave us, is that the only reason why they can prosecute only 2 or for 2 was because When my sister was at life, before she was moved, she was healthy. So her dying was unreasonable. I didn't know whether to laugh, scream, or shout, or throw a tantrum. I didn't know, because for me that was just so unprofessional. It just made no sense. When we asked, have you looked at the other cases? Because in the NGO that my sister was sent to, 22 people died. One NGO, 22 people died. And out of that 22, the NPA could only find 2 people that they can prosecute for. Now, I'm no expert. I'm just an activist. I'm just fighting for what is right. But even with my little knowledge of what is supposed to be, there's no ways. So we told them that we're not accepting that. They must go back to the drawing board. Wrote a very extreme long email telling them we're not accepting that. So our quest for justice is still on. We are not about to step back and say, okay, you know what, we've tried our best, we're not going to do this. And we are grateful for organizations like Section 27, because I don't think we would have survived as families on our own to get this far. But yes, can you please give us the Montgomery judgment? We need it in South Africa. And the value-based approach, that would, honestly, that would be, I mean, if you can just look at it, I think Life Esidimeni is exactly just that case study, because we missed out on all of that. And we still are missing out on all of that, because the deaths are still continuing and the poor treatment is still happening. We don't have a system to deal with mental health in South Africa. We're struggling with health in general. So mental health is not on the radar at all. So yeah, I don't know what else to say, but that's the story of Life Esidimeni, just from my from where I am. And I'm hoping I can answer whatever questions there are. But please remember, I'm an accidental activist, purely from a passion point of view. Thank you.
Thank you so much, Ms. Christine. Thank you for your bravery. Thank you for sharing with us in this session your deepest heartache. And I think all of us here are truly, truly, truly sorry for your loss, truly sorry for all the families that experienced this. And really, I really hope that we can continue in the memory of those families to fight for transformation, to fight for change. And that as the G20 is coming here and as South Africa is celebrating the best of us, I hope we can remember that this was the worst of us in many ways, and that would challenge real transformation in mental health, that would change systems, that would change people. And that's really why we felt that this case study was the most important one for us to really bring forward as a health community. And as you said, something that is beyond horrific, beyond the worst that can happen to any human being. So thank you so much for sharing your story with us today, and for really, I think, giving us more fuel to go forward in terms of approaching the G20 for real reform when it comes to mental health transformation and mental health systems. Thank you, thank you, thank you. And we're definitely going to be coming back to you for a few questions in our panel discussion, but to quickly hand over to Dr. Mistry, just to give us your analysis of this tragedy and the values vacuum that Ms. Christine speaks to, and why this is a case for values within health systems. Thank you, Dr. Mistry.
Thank you, Bettina. And thank you, Christine, for sharing your very personal account, which was really heartbreaking just to listen. We can not imagine what you must have gone through. But what I'm going to be doing here, let me share my screen. Um, are you able to see the screen?
Yes, we can.
Okay, good. Um, I am going to take you very quickly through some analysis that I have done. It's basically values-based analysis on the life Acidemy poem and the tragedy that followed. There's a lot of information out there that I have actually tried to absorb as much as possible in order to do this analysis. It's what I'm going to do is use a structured model that exists. I've also just shared in the chat copies of the slides, so you can actually have a look at them at leisure, but I'm going to go through them fairly quickly. But I'm going to be applying a structured model on analysis on this particular case study to allow us to look at how values were meant to be and how they actually became. So it uses this is a very high level of structure of the model itself. There's more depth that actually follows in a paper that is at the end of the presentation as well. So it uses grid of love versus truth in order to combine a group of activities into values that they portray or not portray. And so what it does is actually just classifies them into these 4 quadrants. So quadrant 1 is the ideal, where we see all values, that have truth and love embedded in them. In quadrant 2, which I've actually put as amber, where there is, truth without love. And this often happens when one is under time pressure, which I'll come on to. And then there's also another quadrant called Q4, which is love without truth, which is when there is cost pressure. And there's the other quadrant 3, which is where we see lack of values. And so I'm going to be using that in its very simplest form. But in order to look at more detailed form, please refer to the paper that I will that I will give out later. So it categorizes values into these 4 quadrants. So applying that in healthcare system means we can actually apply that at policy level, people level, and practice level. And at policy level, it may involve governance, facts and environment, things that are given. Very often you can't really do much about. And by the way, I don't have a medical background, so I'm actually looking at it more as a value specialist rather than as a medical specialist. At people or staff and management level, we can also, apply the same methodology to say, okay, where do the values fall within these 4 quadrants, and where do they fall within the policy? And the same at practice level. This is the delivery and the outcome assessment, all of which I have actually looked at as far as the life Acidemy film is concerned. So just to recap, the life Acidemy home had patients with severe chronic mental illnesses such as schizophrenia, bipolar disorder, severe depression, and so on. And they were all provided with specialized psychiatric care and long-term residential support. Now, using the values, what I have done is compiled a whole series of information, facts, and figures in order to just summarize that into this particular slide to say, okay, what's at policy level, facts and environment level? There was adequate funding at 320 rands per day per patient. It was a licensed psychiatric facility. There were there was service level agreements, and so it was functioning fairly well, and that's why I've actually put it at quadrant 1. At staff and management level, there were trained psychiatric nurses and doctors. Medication management protocols were in place, and service level agreements were monitored and also audited from time to time. And again, things were functioning well. At practice level, patients received good care with active participants in their care. The providers were satisfied, and there was generally good operational efficiency. And at community level, there was, general satisfaction. Now, I'm just going to look at one value out of several that I have actually looked at. But Ubuntu is a relational value. So it basically relates to context and the environment that one finds themselves in. And by the way, there are 2 videos here which I have actually given links to, which goes into the kind of further nitty-gritty level detail, not on the case study that we're looking at, but the general methodology. And so if we look at Ubuntu, if we were placing that in quadrant 1, then we would expect staff giving prognosis gently and kindly with support. If we find that staff are giving harsh truth without encouragement or emotional support, then this is where it would be placed. And as I said, this is when there are real-time pressures. But when there are cost pressures, we often find that staff will do their best in order to, do their service as best as they possibly can and take a lot of care. But they can only do so much, and there may be times when they're actually soothing the patients without the truth about their prognosis. And this is something that we did see in the life acidity example, where staff were treating patient as a number in a highly cost-cutting environment. So what happened after the change? And this is really, I hope it kind of reflects some of the things that Christine has shared with us just earlier. So at the policy level, facts and environment, we found that there was inadequate funding. Only 1/3 of what there was given earlier, and there was a delay in actually delivering that money as well to the relevant community-based homes. Those homes were mostly unlicensed and unregulated homes, so there were no enforceable service level agreements as such. At staff and management level, there were minimally trained caregivers, there was medication shortage and mismanagement, and patients were transferred without records with little or no oversight as such. And as we saw in the account earlier, that 144 patients died, providers were caught up, and there was a lot of inefficiency at the same time as well. And at community level, most of the stakeholders were criticized. And as you can see, I've actually, based on these facts and the findings, I've actually scored the policy level and at Q3 and Q4 level. Q3, but really it was more like Q4 as outcome. The staff management was there. People tried to do their best, but could not. They had to be somewhat reserving some of the information from the patients or those that asked. And it really appeared as Q3. which is where there is this is where we are grouping values, which shows there was no honesty and no care as such. So the inquiry that followed, and there was a health ombudsman report as well, which concluded that the project was irrational, unwise, and inhumane. The deaths were a direct consequence of government policy failure and gross negligence, and it recommended licensing and monitoring of all mental facilities, compensation to families, and criminal investigation into responsible officials. This is just another way of analyzing, values of Ubuntu, what we found in the case itself: harshness, false comfort, and so on. I won't dwell on that because we have little time. But at the end, I have actually given reference to the actual slightly more detailed paper that goes into the methodology as applied in healthcare system as such. So that's all I want to kind of say at this stage.
Thank you so much, Dr. Mistry. And I think that really gives an overview of the case study we've done, looking at life-assisted tragedy and the intersection of values. And I think your work in looking at truth and love and the absence of both truth and love in this case study largely, I think, really drives home the role of values in shaping our system. So thank you so much for that presentation. And Dr. Mistry will put a link to the full paper that he has written, which analyzes from a values perspective, the case study that we have just explored. So thank you, Dr. Mistry. We're now quickly going to go into our panel discussion, just to unpack some of the issues that we've been hearing here and getting perspectives from experts in terms of what should our recommendations now going to the G20 conference, going to the V20 conference be? Where are the gaps that we are seeing really in mental health care access in South Africa and globally? And what do we need to be focusing on? So for this panel discussion, would love to welcome again to the table Ms. Christine to join us, as well as Prof. Verdi van Staden. Prof. Verdi van Staden is the Professor of Philosophy and Psychiatry and the Director of the Center of Ethics and Philosophy of Health Sciences at the University of Pretoria, as well as an honorary psychiatrist at Westkoppies Hospital. And as we were working on this case study, we actually came across a work that you had done in the Oxford book on mental health practices, where you explored the same case study and the role of Ubuntu and the role of really having community-centered practices in shaping mental health care going forward. So thank you so much, Prof. van Staden, for joining us today. And joining us as well will be Ms. Sasha Stevenson, who Ms. Christine spoke about before, who's been leading Section 27 and has been such a prominent activist for mental health. She's a human rights lawyer and executive director of Section 27, as well as a public interest law organization in Johannesburg. She holds a bachelor's, honors, and law degree from Rhodes University and an LLM from the University of Cambridge. And she has over 10 years expertise in shaping health systems and health rights from the human rights perspective. So Ms. Stevenson, thank you so much for joining us today and for the exceptional work that you do in Section 27 and really bringing home the human right that everybody has to health and to dignity and dignified health systems. And our last speaker for today is going to be Ms. Cassie Chambers. Ms. Cassie Chambers is the Operations Director of the South African Depression and Anxiety Group, and she'll be speaking to us a bit more about the kind of climate we are seeing in mental health access at the moment. So, Prof. van Staden, maybe just to begin with you, we've heard from Ms. Nxumalo, we've heard from Dr. Mistry. In your perspective, what should be the key lessons that we should be taking forward going to the G20 in terms of lessons from the life epidemic?
Thank you very much, Bettina. Thank you for the opportunity to participate in this discussion. I think I would like to begin with the point Ashok has begun with, and that is values are really about many things, very heterogeneous, and there's a real risk that we do not appreciate the scope of what values are about. And I would like to begin with differentiating between two kinds of values, those values that we share and those values that are really different. And the shared values we've heard quite a bit actually about today, and they are really very important. Those values we've mentioned: importance of dignity, ubuntu, compassion, accountability, equity. Those are the values that we share, and they are certainly in play and crucially important. Those are the values that you also, Bettina, alluded to, that you want to embed in healthcare policy. So that's, in a way, values that we bring to the mental health care policy and framework. So that's the shared values, important as they crucially are. On the other hand, there are values inherent to each perspective of the various stakeholders. And they are not brought up to bear upon, they are already there. In the decisions, in every decision, in every perspective, you will find the values inherently there. And we need to deliberately cater for those values as well. So it's not only bringing and applying the shared values. We should have scope for those values, important as they are, but we should also bring and make space for those values that are already there in the perspectives of the various stakeholders. So we've heard about, in the Life is Epidemic Tragedy, about the lack or the absence of values. But what we should really appreciate there is we can think of that lack or absence in two ways: about the shared values that should have applied and did not apply. For example, people did not operate in an ubuntu way. Yeah, that's the shared values being amiss. But on the other one, crucial importance is that some values, or the values of some stakeholders, I should say, did not feature in the decision making. So there were values in the decision making, but policy particularly of the government officials who made the policy. But what was absent there were the different perspectives of stakeholders that were not accounted for, and they were shouting, as we know, they were shouting in advance, the court actions and so on. Say, listen to our perspective, and people did not listen to those legitimate different perspectives. So what should be in our policy reform is, of course, the shared values that should frame and guide us. But what we should also have in our policy reforms is provisions for differences. And one can phrase it like this: how may the resulting policy account for the differences between the values of the stakeholders without dismissing or changing anyone's values? So this is not necessarily seeking the conformity, because it's not about the shared values only. It's deliberately also about the divergence of values. So we're talking about differences, variety, diversity. That's what we're talking for which we need to make provision in the policies, in averting people not listening, not only not listening to the shared values, but also listening to the individual or the values inherent to perspectives and decisions. Thank you.
Yeah. Thank you so much, Prof. I think that's a very helpful way to look at it. And I think really, going forward, looking at how do we, in policy, create space for difference? How do we listen more actively to different stakeholders before making a policy decision? I think this really was a case where different stakeholders and their opinions were not taken into consideration before actions were actually taken. So thank you very much for that perspective. And I think to come to you, Ms. Stevenson, and the work that you've been doing in the Life is Epidemic Tragedy, in your opinion, have you seen there being systemic reform at present? Since the Life is Epidemic Tragedy took place, has there been systemic reform? And if not, what do you think are the key areas we need to actually be advocating for going forward as lessons from the tragedy?
Thanks, Bettina. Thanks, everyone. Prof. van Staden's comments about there being alternative values or different values that were applied in this decision and in the implementation it's not a way I've seen it before. I think he's right that we do focus on the shared values, and to me and to us and to almost everybody who's seen this case and worked on it, it's just so clear where things went wrong, and it's because the shared values weren't taken into account. And I think when we think of the the values that were applied on the other side when it comes to the person making the decisions, Ms. Mahlangu, the former MEC for Health in Gauteng, the people implementing the decisions, these people whose actions have now been found to be suitable for prosecution. The so-called values that they were using were just in most ways thoroughly abhorrent, but in some ways there were the concerns about funds, the concerns about rationalizing care, the worry about prioritizing certain populations. So I think that's an interesting way of putting it that I just wanted to highlight to start off with. I think despite this being, as you said in your intro, one of the most horrendous violations of human rights that we've seen in the democratic era in South Africa, we haven't seen nearly enough when it comes to systemic change. So in this case, we've gone through, as Christine said, various processes. We've gone through a health ombuds investigation. We went through an arbitration that took 43 days and had lots of people giving evidence. We went through an inquest, which took 143 days, saw even more people giving evidence. 60,000 pages worth of evidence, a recommendation for prosecution, implementation of compensation requirements and requirements in the arbitration for a systemic reform of the mental health care system. So despite all of that, we haven't seen the kind of reform we need. What we saw immediately after the arbitration, when we, because we analyzed in the course of the arbitration, the budget arguments of the state, and the fact that one of the arguments was that Gauteng Health, the provincial health department that was responsible for this disaster, couldn't afford to pay the 320 Rand per person per day, which for people abroad amounts to about 15 pounds per person per day. Couldn't afford to pay that, and so needed to pay less than half of that amount. We'd heard about that, and so we analyzed the budget of the Department of Health to see how much was being spent. And firstly, that turned out not to be true. And secondly, it did turn out that there was allocation to mental health. It had been increasing, but was insufficient, and that there was no budgetary justification. But what we saw after the arbitration, having done that analysis, was there was an increase in the budget for mental health care services in the province. And we took that as a good sign that there was a good faith effort to improve access to services. Unfortunately, what we've seen in the years since has not been a continuation of that turnaround. Mental health still remains a very small portion of the budget. And even our health minister, who was health minister at the time, by the way, recently said that whenever there's a cut to budgets, mental health is what gets cut. He, of course, is the Minister of Health, and while he doesn't control the Treasury, he does certainly ask for budgets. And so that can't be said in a completely values neutral way, but I'll leave that point there. So we haven't seen an increase in the budget, and we also haven't seen an improvement in access to mental health care services. In particular, we haven't seen the kind of improvement we'd hope for in community mental health care services. Much of the budget that was sitting with Life Esidimeni got diverted to the psychiatric hospitals, which of course themselves desperately needed more budget, but the money wasn't following the patients in the way that it's supposed to. And we haven't seen, and partly as a result of that, we haven't seen the systemic change. In fact, just a few years ago, we had to stop a similar thing from happening again at the Solomon Stix Morewa Hospital, where Gauteng Health, many of the people who were new, because many people responsible for Life Esidimeni or involved in the disaster left, had decided to close down yet another mental health care facility. And we had to go in as activists and family members of the victims of the Life Esidimeni disaster to say, do you remember what happened last time you wanted to quickly move people out of a chronic mental health care facility? Unfortunately, we were able to stop that. So we haven't seen that kind of change that we certainly need to. And I think what's problematic there is that, we have these rights that are provided for in the Constitution. We have values that are espoused that align very much with our constitutional rights. We have this sort of saying and legal culture that the era of constitutionalism, the democratic era in South Africa shifted us from a culture of authoritarianism to of authority, although also authoritarianism, to a culture of justification. And so decisions have to be justified and have to be in line with the Constitution and have to be in line with values. We're not seeing that shift. And that means that we continue to see a mental health care system that doesn't cater to the needs of people. We continue to see a lack of accountability, as Christine referred to. And as a result of both of those things, we continue to face a risk that mental health care users will remain vulnerable to the non-application of shared values or the application of values that are really contrary to both their interests and the interests of everyone in South Africa.
Thank you so much, Ms. Stevenson. That is in many ways disappointing that there's been such little reform and change being done. Though I think Life with Sidimeni has been spoken about in so many spaces as a case study for reform and for change. And maybe to bring this question to you, Ms. Chambers, it's hard in the mental health care space because we have the evidence. We know that there is a lack of funding. We know that mental health is integral to so many other elements of health. We know that investing in mental health is good for returns. All of this evidence exists. So when it comes to advocacy, really, where are the bottlenecks that we are facing in terms of really moving, the pendulum forward in creating true transformation in mental health systems? And how do we begin to play a role in moving that pendulum forward as advocates and as individuals who want to engage with G20 leaders going forward?
Sure. Good question. Good afternoon, everyone, and thanks for having us. I think it's also just such an important conversation to have, especially ahead of World Mental Health Day on Friday. It helps to frame the importance of mental health. And I think, everyone that's joined this afternoon can talk about the consequences if we do not invest time, energy, policy, support to mental health. It has fatal consequences, which a lot of people often don't realize, that by not prioritizing and investing in mental health, it does have these impacts. And I think when we're looking at so much and the history of what we've been through and what we've tackled, and Sasha covers it so well, in that there were these really pivotal moments and pivotal policies and documents that we've had in place, which we've never had in place, like the Ombuds report, the South African Human Rights Commission report. We have all these incredible recommendations. I think where we're seeing from an advocacy perspective is we're not seeing that those recommendations are being implemented. And I think the follow-up of that, as civil society, and that power of collaboration is so unique. And having, human rights lawyers, a Section 27, SADAG is civil society. We also partnered with SASOP, which were the healthcare professionals, and the family committee, coming together kind of from this multi-sectoral base in really advocating that now a lot of what we're having to do is to make sure that we're following up on those recommendations. And perhaps to some degree, it shouldn't be our job to tick the things that have been said that you have to do and should see that improvement. And often that report card can be quite difficult to digest because it does feel like we haven't moved forward. And I think in the work that we're also doing on a day-to-day basis, unfortunately, we're seeing other tragedies. Just recently in the Northern Cape, we had seen that, again, mental health patients were treated ill, were left without electricity for a year, did not have treatment, and they died from these basic human rights that they should have had in care. And I think as an advocacy group, it can be incredibly hard because you're having to really push and motivate and be on top of it and follow through with those recommendations that we have in paper are so good and so clear, and speaks again to that patient-centered approach. I think it's really hard when the people, the powers that be, those big decision makers, are not necessarily on top of it as they should be, and they should be giving us updates and not necessarily us following up. But I suppose as an advocacy group, I apologize, it's a lot of the work that we're having to do to follow through with that. I think when we're looking to access to care and advocacy, is that we know that specifically in mental health, we're seeing a big crisis in mental health, which to some degree, especially in South Africa, we were dealing with pre-COVID. And then COVID came, and we've seen that that's really highlighted those mental health issues. And again, with life Esidimeni as an example of the difficulty of accessing care as the community, as the public, and having to reach out. And I think one of the lessons we've learned as part of our advocacy is to really empower family members and patients and loved ones, what treatment should look like, what kind of care you should be getting. And those human rights is really integral. When we're looking at kind of where to here or advocacy, it's really looking that treatment reaches the people, and really keeping on top of that and making sure that we have a seat at the table. I think one of the lessons we've learned through the Life Esidimeni tragedy or disaster is that NGOs and civil society and these other stakeholders are key partners, often not the enemies, but key partners in really making change. And again, that shared value and making sure that we have a seat at the table, that we're not just a tick box, but that we are actually partners to work together. We've seen some of those changes, but not enough. And I think it's always just about pushing that needle to make sure that we are included in those conversations, we are included in those meetings, and that it is taken seriously. And I think that power of collaboration is really key in advocacy, especially with mental health. When we still have the stat that 9 out of 10 people with a mental illness in South Africa do not have access to treatment, we have to do better. And it starts with advocating to government. It starts with advocating to hospitals and making sure that our mental health care system is so much better. But that takes energy, and that takes time, and that takes resources. And I think in working together collaboratively has been integral for SADAG to be actually pushing that needle for change in South Africa.
Thank you so much, Ms. Chambers. Thank you for that. And I think, you speak so well to empowering families, empowering the patients to be able to demand for better. I think that's also one thing that we have tried to highlight in our communique, is that I think especially in a lot of low and middle income countries, patients have become comfortable with the bare minimum that health services give them. And I think really understanding what is quality care and how do you advocate for that quality care is so important. Maybe then to come to you, Ms. Christine, you've been doing so much work in the family group and with the family group for Life Esidimeni. Where is the role, and what do you think we need to do to really ensure that community voices are more empowered to take center stage in advocacy when it comes to mental health? Thank you, on mute.
Thank you for that. Look, what we've learned with the Life Esidimeni tragedy is that because our voices were deliberately left out, the tragedy happened. And because our voices were not there, even as things were moving, that is why more and more people died. Because had we known where people were or whatever, we probably would have been able to get there quickly, avert the disaster, or at least minimize the deaths or something. But I think the manner in which it was done, it was deliberately done so that the families are not there. Because immediately when the families started being part of the process and standing up and fighting and you started seeing the, I don't know what you call it, the pushback. I think, look, after the tragedy, the awareness is there from the community. I mean, every corner you turn, every pamphlet you get, you hear about mental health. People speak about it. I think what it has done, it has actually taken away the stigma part of it. And I'm not pronouncing that it has actually taken away the stigma, but I think people are a bit more comfortable to talk about mental health. People are actually comfortable to say, I'm not well, or I need to go and see a psychiatrist and stuff like that. Whereas before, that wasn't it was something that we could not talk about. Without the families and without the community to leave government to do things on their own, it's just never going to work. Because without the families, how are they going to know what they are doing has an impact, or what kind of impact it has? You know, it's one thing to just deliver a service and not really know how it's going to, or how it's being delivered, what impact it's having, whether it's making any change of any kind, or it's just something that they just throw money at it and we've delivered. So it is crucial. To answer your question plainly, it is crucial to have families. And I think one of the things that has actually shifted, I think there's now advertising of board members in terms of including family members in some of these decision-making bodies, to say that without families, you really cannot provide a complete service because you don't know how it's impacting. I think families and communities are actually a crucial part of the process. So without it, I don't think we'll ever get that holistic approach to services. So yeah, to answer your question plainly, we cannot do without family members. And this, as a stakeholder, yes, we cannot do without family members.
Thank you so much, Christine. I think that definitely speaks to, so importantly to the value of Ubuntu, and ensuring that, all of us are collectively shaping health systems going forward. We are a little bit over time, so I'm going to quickly allow for 2 questions from the audience, and then we will wrap up just with final thoughts from our panelists. So are there any 2 questions from our audience members for our panelists today? So I will take up less time to allow for audience engagement. I'll also check the chat to see if there are any questions in the chat.
Nothing in the chat.
Yes, Miss Katrina.
Gara, thank you so much. It's been an absolutely fascinating discussion. And I want to very briefly reflect on a few things that I've heard. One of them is coming back to things that Ashok had talked about right at the beginning, about the perceptions of values and managing the perceptions of values, and what it is that, and what Weirdy has also said about the differences in values. And I think that there is a disconnect between what someone's expectation is as far as values and the delivery of values is concerned versus what can be delivered. And I think that there's a divide between that, and how we bridge that gap is something that we need to overcome. I don't know how to do that, but I think if we can master how we can understand what the perception of values and the delivery of values is versus how we then measure that collectively, it's a difficult thing to do, but that there seems to be an answer that sits in there. And I'd just like to hear what, from a medical perspective, how are those things measured, and is there a consistency of measurement in that, those perceptions of values, and the subjectivity that sits with that? Is there any best practice that we've seen in terms of where that's done well?
Thank you, Ms. Katrina. I think maybe Prof. Verdi, starting with, maybe you could speak to that.
Thank you. Katrina, I hope I'll be able to get to your very difficult questions, but I would like to just begin and touch on Christine's incredibly important point, and that's the crucial place of families and patients as stakeholders, and that those values must be heard and then be listened to. So that's the ad. It's having a voice, but it's also then listening to the various voices. It's not just about having a voice. It takes it. We must listen to the various perspectives and then account for those perspectives in our decision making, not selectively and not autocratically and not, my way or no way kind of approach, but deliberately finding creatively ways in which one can then make decisions that accounts also for the differences. And the values-based practice is very neatly worked out guidance with pointers how to do that in the details of it, and really draw on that. And it's really a creative process. It's not answers that we will easily necessarily find just from a shelf. It's really, we need to engage. What does it mean in our particular context? What we're going to decide in terms of accounting for the various perspectives. So that is, I think, really the important thing. Measuring that is indeed quite a challenge. So there are good practices established. We can typically just measure parts of it because it's just too much of an undertaking. It's just too a broad undertaking to really get a grasp on measuring that. But we can gauge that process. And crucially, it is for the very people in the process to gauge it for themselves and for ourselves in the process. How well are we doing and accounting for the differences and listening to each other and accounting for the differences, not just where we share an objective or share values, but also to hear where we, have different views.
Thank you so much. Thank you. I think that really gives us a framework in terms of starting to think about how do we gauge that perception of, incorporating different values within the system. And thank you for highlighting again the importance of family voices. And Anna has also just put in the chat as well that listening to different perspectives and including the possibility for thought ones is really important when we are dealing with this work. So thank you so much for that. Is there any final question from the audience before we wrap up? If there are no final questions, I think Ms. Stevenson, when we initially spoke about maybe the values that we don't necessarily speak a lot in this case, with the values of individual people within the Department of Health, individual people who took on patients at the NGOs. So how do we really get to helping individuals in a system where there is corruption, for them to really live out their values and to stand up for what is right, and it might come at a cost to them? I think that's something that we spoke about before, and I think it's very important in this case.
It's a tough question. I think you're right. There were many people involved in this, and not everyone was, going out to get this project done. And yet, somehow, the machinery of the Gauteng Department of Health carried out a project in which about 1,400 people suffered and 144 people died. And so you have to wonder how the different role players within that were corralled and intimidated and pushed and convinced into playing the roles that they played. And I think that says something about leadership and the importance of values-based leadership, which is something we saw a thorough absence of in this case. And it shows the importance also of an institutional culture that is values-based, which we also saw an absence of in this case. When I spoke about corruption, I wasn't speaking in our initial discussion. I wasn't speaking specifically about the kind of corruption we see, frankly, in South Africa and many places around the world all the time. The I do you a favor, I get money for it kind of corruption. But about a concept of institutional corruption, a concept where the institution becomes corrupted into, for whatever reason, into going in the wrong direction. And that becomes okay and the norm, and people are able to be drawn along. And I think that's what happened in the Gauteng Department of Health in this period, is that, and this is not to take away the responsibility and accountability of a few people who do need to be prosecuted for culpable homicide in this case, I have no doubt. But this culture of listen to the boss at all costs, regardless of the fact that there are mental health professionals under her telling her what should be done, and she's not listening to it as the politician and pushing forward anyway. That culture of do what I say or else you're out. Don't speak on behalf of families, or don't make it look like you're supporting Life Esidimeni, because are you working for them or are you working for me? The idea that you should close off to anyone from the outside, that the South African Society of Psychiatrists, predominantly public health sector mental health professionals, shouldn't be part of meetings with civil society because they should be with government because they're employed by government. That kind of culture is what's deeply problematic, and what needs to be what needs desperately to be shifted. Because without that kind of culture shift, it is extremely difficult for the many good people in the system to stand up. And in fact, we saw very few people standing up. We saw a number of psychiatrists standing up when grouped together, which is an important message for healthcare advocacy in general. We saw a few officials in the Gauteng Department of Health standing up. But most people, while some may have expressed some discomfort or uncertainty or lack of agreement, most people who were central to the project pushed along with it. And I think that speaks to values, it speaks to culture, it speaks to leadership. And without fixing those things, we're in a lot of trouble. And I think a real expression of values and the importance of listening, as everyone's been saying, of acting in line with the Constitution, which in South Africa gives us, perfect clarity as to what would have been required in this case. That's really what's required to prevent a disaster like this from happening again.
Yeah, I think it is a very complex question of how do we build that kind of, values-based leadership internally. But I really love what you said about, I think values are often easier within collectives as well. So I think, organizing within health advocacy groups allows individuals to be able to live out those values more. And I think the complex work then of how do you deconstruct an institution that has gone the wrong way. It's very complex. And I think something that really needs values practitioners and individuals in this room to really think about more in terms of how do we shift culture back to one where values can be supported, where people can stand up for their values. Ms. Katrina, is that an old hang? Are you captured?
No, it actually, it's just to reflect what Sasha's saying, to be honest. As someone who writes policy, I come from that culture where you end up in a firefighting responsive manner because you're trying to prevent something happening again, as opposed to prevent something from happening. And it's an unfortunate case where disasters like this actually have more of an impact than the preventative elements, because it's very difficult to measure preventative impact because the disaster didn't happen. So it's very difficult to get that prioritized up the stream. And as government, there is no end of problems that are being thrown at you, and you have to respond to it is a very responsive environment. And I think that you're right, that comes back to culture, which is what Ashok had mentioned before about you can ask an individual about their individual values, and those would be about transparency and doing the best. But when you come to the brand of the department or the brand of the organization, there's usually a disconnect between those two things. So yeah, I think if the work that Mesh does looks at a way in which we can elevate proactive policy that's preventative, especially in healthcare, where healthcare is about people, then that would be something that, Bettina, I'm sure you'd agree that if we can find a way of elevating those policies that prevent things from happening as opposed to respond to things that have already happened, then we'll have fewer people like Christine having to share their stories in order for us to actually move the ship. Does that make sense?
Definitely in agreement. I think we have a tendency, especially in South Africa, to very reactive policy making that react to tragedies. And I think we often need a lot more proactive policy making from the get-go. So I think definitely that is something we need to take away from this section. Thank you so much, Ms. Katrina, for your feedback. And thank you to everybody in this room. I think we are almost at 2 hours. I don't want to get to a 2-hour mark. So I really do want to thank everybody for taking your time to be with us in the session. As Ms. Cassie Chambers said, it's World Mental Health Day on Friday. And we really want to carry this conversation forward, going into the Values 20 conference that is happening on the 17th and 16th of October. that Charles has put in the chat. So please do sign on to that, be part of that conversation, to continue to move this conversation beyond this room into those places. Thank you so much to Charles for facilitating this conversation for us today, for Prof. Handa, for your beautiful collaboration and partnership with us to make this webinar happen. To Miss Christine Xumalo, thank you for sharing your story. Thank you for really coming onto this platform and bringing this conversation home for us, making it real for us in terms of people who are truly affected when policies go wrong and when they happen without values in mind. Thank you to Prof. Van Staden, to Ms. Sasha Stevenson, to Ms. Cassie Chambers. Thank you for all the work you do outside of the space to amplify and to advocate for mental health advocacy. Thank you for that. Thank you for joining us today and making this webinar happen. We'll definitely be in contact with everybody who registered for this session with more information about the Values Conference as well as a write-up of this webinar as well in terms of key issues that came up today, what we'll be taking forward going into the Values 20 conference. And I think with that, we can close this session today. Thank you all for being here. Really, really appreciate it. And hopefully, collectively, we can continue the work of trying to transform mental health systems for everyone. Thank you so much.